SIADH, Syndrome of Inappropriate Antidiuretic Hormone. What is the syndrome of inappropriate antidiuretic hormone secretion? Vasopressin is secreted even when plasma osmolarity is low or normal. Vasopressin is the same as ADH, antidiuretic hormone. They're used interchangeably. Feedback mechanisms do not function properly. It could be a cause. Water is retained, resulting in hyponatremia, low sodium, dilutional and expansion of the extracellular fluid volume. Not because patient is losing sodium levels. Accompanies potassium loss with sodium loss, hypo Na sodium, and hypokalemia, potassium. Urine becomes concentrated and urinary output decreases. Increased blood volume inhibits the RA, the renin-angiotensin system, causing more sodium to be excreted. This leads to greater hyponatremia. More sodium is lost. Leads to greater hyponatremia, low sodium. What are the multiple causes of SIADH? Assess and see if there has there been a recent infection or head trauma, TIA, CVA, so the TB or other pulmonary disorders, cancer could cause it, current or past drug use, opioids can cause SIADH. Review patient current medication list. Infections such as meningitis, encephalitis, abscesses, herpes zoster. Vascular causes are thrombosis, subarachnoid or subdural hemorrhage, temporal arteritis, and stroke. SLE. Cancer, primary or metastatic, a skull fracture, head injury, pulmonary disorders such as pneumonia, viral, bacterial, fungal infections, TB, lung abscess, empyema, acute respiratory failure, asthma, COPD, atelectasis, pneumothorax, cystic fibrosis, positive pressure ventilation, severe nausea, pain, infection with HIV, post-op patient. Drugs, cyclophosphamide, carbamazepine, chloropropamide, vincristine or vinblastine, thioxine, thoridazine, haloperidol, tricyclic antidepressants, those are the TCA or SSRIs, MAOIs, monoamine oxidase inhibitors, bromocriptine, lorcainide, clofibrate, general anesthesia, opioids, nicotine, and fluoroquinolone antibiotics. Assessment findings for a client with SIADH. Early manifestations of this SIADH would include anorexia, nausea and vomiting, weight gain. So that's anorexia. They see that as loss of appetite. As blood sodium level decreases less than 125 sodium, anorexia, hostility, sluggish deep tendon reflexes, nausea and vomiting, diarrhea, and oliguria. So no urine and the urine becomes dark yellow, concentrated urine. Seizures can develop with low sodium, less than 125. Normal is 135, remember. Muscle weakness, irritability, malaise, anger, anxiety, disorientation. This is all with SIADH. Uncooperativeness, lethargy, seizures, and coma with a sodium less than 125 as sodium decreases. Seizure are more prevalent. Hypothermia. Remember with DI you had hyperthermia. Now with SIADH you're going to have hypo, low temperature. DI look for signs and symptoms of dehydration. With SIADH you're going to look for signs of fluid overload. SIADH fluid overload such as fluid volume access. These symptoms would include tachycardia, crackles, bounding pulses, hypertension because of all the fluids, distended neck veins, weight gain, manifestations of fluid volume access. Results of laboratory testing for SIADH. SIADH urine is concentrated, so think concentrated urine, increased sodium, increased urine osmolarity. As urine volume decreases, urine osmolarity increased, more concentrated. Blood, with the blood and the SIADH, you're going to think of dilute blood. So decreased blood sodium, dilutional hyponatremia, decreased blood osmolarity, less than 270 MEq per liter. As blood volume increases, blood osmolarity decreases. How is SIADH diagnosed? We have the serum ADH test, fast and avoid stress for 12 hours prior. So you have to fast and try to keep your stress low for 12 hours prior to the serum ADH blood level test. Some medications can interfere with the test, so consult your provider if medications need to be withheld. Serum electrolytes and osmolarity, low serum sodium and chloride. Urine electrolytes, osmolarity, and specific gravity. Increased urine osmolarity, increased specific gravity, increased urine sodium. What medications are prescribed for a client with SIADH? Tetracycline, derivative demeclocycline, antibiotic off-label use is an SIADH. Works by, so with the tetracycline, it's an antibiotic, but it's an off-label use for SIADH. So it helps to correct fluid and electrolyte imbalances by stimulating urine flow. Problem is it is nephrotoxic to your kidneys. It's a newer drug. Vasopressin, which is ADA's antagonist. PO drug is tolvaptan. Black box warning, CNS demyelinization and hepatotoxicity, that's the liver. Do not use with liver disease or longer than 30 days because it could be hard on your liver. Demyelinization is nerve damage, destruction of myelin sheath. Happens when sodium levels are corrected too fast. Appears not till 2 to 3 days after sodium corrected. Trouble speaking and swallowing, impaired thinking and weakness. Important to remember of these drugs is they do not correct serum sodium level, or you don't want to correct that sodium level too fast. IV drugs, conivaptan for hospitalized clients. This is through IV. Conivaptan can promote water excretion without causing sodium losses. Tolvaptan, black box warning, due to hypernatremia leading to central nervous system demyelinization. To be careful with this correction of sodium too fast. Can cause hepatotoxicity, should not be used for longer than 30 days and not indicated for those with liver disease. Diuretics can help to decrease excess fluid volume. With diuretics, they can worsen hypernatremia. Reserve these diuretics when heart failure is present or electrolytes are near normal. Furosemide increases water excretion from the kidneys, so that would help the fluid overload, but then it can worsen your hyponatremia. What medications are prescribed for a client with SIADH? Hypertonic sodium chloride IV fluid when sodium level is severely decreased. This is a 3% saline. I guess the hypertonic sodium chloride would help raise the sodium. Issue with this is that this can lead to CNS demyelinization because the patient's serum sodium level should be drawn every 2 to 4 hours. You have to monitor closely. Provider can make adjustments in administration in serum sodium. Elevate serum sodium level to alleviate neurologic compromise, severe hyponatremia, water intoxication. Administer 200 to 300 milliliters hypertonic IV fluid, 3% sodium chloride. This can cause fluid shifts from cells into the intravascular space. That's with this hypertonic IV fluid can cause fluid shifts from cells into intravascular space. Hypervolemia, monitor for fluid overload symptoms. Hypertonic is reserved for those that have severely low serum sodium levels. Do not correct too fast. Patient will require frequent sodium to test levels. Requires careful monitoring of serum sodium levels drawn every 2 to 4 hours and results reported to provider. Monitor for hypervolemia. So this is the end of slide 23, which ends DI and SIADH. What should be included in the plan of care for a client with SIADH? We're wrapping it up here, but for this plan of care, we'd have strict fluid restriction, be kind, because they're having fluid overload, so we don't want any more fluids, but comfort measures for thirst, ice chips, lozenges, frequent mouth care, staggered water intake. Fluid restriction is 500 to 1,000 milliliters per day, strict INO and daily weight. Notify provider of weight gain of greater than 1 kilogram. Remember, that's 2.2 pounds. Maintain safe environment due to low sodium with neurologic assessment every 2 to 4 hours. Report altered mental status, headache, confusion, lethargy, seizures, or coma. Remember, seizures with the low sodium. Avoid alcohol, ETOH. Avoid medications and food that give diuretic effect. So we're going to wrap up SIADH here and move on next to the adrenal disorders with slide 24.